So, welcome to welcome to our Kiwanis meeting for today. I want to welcome guests that we may have. I see Sarah Saft is one that's here. Bailey Belcher. So may have some other guests, and I want to make sure to welcome them to the meeting today. Greg, do you have a thought for the
I
day?
have a lot of thoughts today, Eric, but first the thought I was going to have was a moment of silence for the terrible disaster in Kerr County, Texas, and the loss of those children and the loss of families. I couldn't sleep last night thinking about losing a child like that. Maybe a moment of silence to hope citizens can act to protect themselves. Thank you. So a couple real quick things. On July 9th, 1868, America adopted the 14th Amendment to the Constitution after the Civil War to allow blacks to vote, to end slavery. The 14th Amendment was codified with all those things you hear about on a daily basis, equal rights and liberties for all. Birthright citizenship is part of that. Then I wanted to read, as I often do, a couple of comments from Eva Core, who always told me to be positive, never give up, prevent prejudice by judging people only on their actions and the content of their character. Forgive your worst enemy will heal your soul and set you free. Give your parents an extra hug and kiss for us children who had or have lost parents. And each of us has an opportunity, an important part to play in repairing our world and our country. That's enough. Thanks.
Yeah, that is a lot of thoughts, Greg. Thanks very much. There's a lot weighing on our shoulders right now.
Thanks, Harry.
But some good comments. I will make a few announcements. First, I get to officially announce your club officers that will begin on October 1st. I'll continue as the immediate past president and serve as the 2026 foundation president. Club president-elect will be Jeff Otis. I'm sorry. Roger Cummings will continue as treasurer. Kelly Oles is appointed as secretary, ex officio. And Steve Farrow, Laura Holloway, Art Kordroff, Chuck Cotterman, and Greg Silver will continue as directors. So many thanks to all those folks, and a particular thanks to Jeff for stepping up to take on the presidential role. Thanks to Mary Marsh, we have a special lunch with Howard Kellum and tour of Victory Field on Wednesday, July 30th. Please RSVP if you can by Tuesday, since we need to lock in numbers and ensure that we have enough people signed up. The cost is $25 and includes a boxed lunch and complimentary parking. Our foundation's development team, led by Mike Halstead, reports several key sponsors for our golf outing on Tuesday, the 23rd of September. Thanks to title sponsor Neo Engineers, silver sponsor Gelser Investment Management, and whole sponsors BCMI, Rockefeller Capital Management, IHSAA, Patterson Horth, Diversified Roofing, and many more in the works. You can sign up to participate or volunteer at indykiwanis.org. Thanks to Eric Steele for his leadership in getting this relaunched. Next week, we will be back at the Columbia Club on Thursday for our third Thursday lunch. Some upcoming Zoom meetings that we have scheduled: author Ashley Petrie and her new book, Amazing Indianapolis, on August 7th. Gerald Harkness with his documentary When Everyone Swims on Thursday, the 14th of August. And on Thursday, 9/11, Remembrance with Indy Northwest Kiwanian and American Red Cross incident responder John Bloom. Other upcoming speakers include Professor Paul Cook on artificial intelligence, Chuck Lofton and IBJ's Mickey Shuey. Don't worry, if you missed some of our great speakers, you can always catch up on our presentations on our YouTube channel and find recordings in the upcoming events section of the website. Mary, do you want to touch base on social suffers? Is Mary on?
I don't think she is.
Okay. Well, I know that we had a record turnout at our last one. We were at Hollyhock Hill, so lots of partaking of fried foods and a good old family style meal, and had a terrific turnout for that. I do know that if you make a reservation or indicate that you're going to be there, please follow through and be there. We've had some last minute cancellations that caused some awkwardness. Roger, you want to touch base on IOZOs?
Oh, just quickly, next Monday, the 14th, we're meeting at IOSA for lunch, 11:30. Plenty of seats available. Come and join us. Just let me know.
And
Email,
Chuck,
email or phone. Sorry.
Yeah.
I'm
Sorry,
done.
didn't mean to speak over you there. Chuck Cotterman, you want to touch base on football? Chuck not here either. I guess we have locked in on December 4th for the Marion County football lunch with the Colts. So please mark that date on your calendar. That's a really fun event and great to get out to the Colts practice facility. How about an icon update, Laura?
Yeah, I'd be happy to provide an update on behalf of the key clubs that we helped attend ICON this year. We had representation from Shortridge, Perry Meridian, and the Speedway high schools, key clubs. And to share the sentiment, I'd just like to read a little bit from our governor, Sweet Knight from Shortridge High School. She sent us a thank you message right after coming back. She wrote, "All of us had an amazing time meeting like-minded individuals from all around the globe, developing connections and being a part of the voting process for our new international board and being involved in proposing amendments. We even got to witness the gavel pass from Key Club International presidents. Overall, I cannot stress enough how ICON was absolutely an incredible, emotional, and fulfilling experience. On behalf of Shortridge High School, Perry Meridian High School, and Speedway High School, I would like to express my sincerest gratitude to the Kiwanis Club of Indianapolis for sponsoring us this trip. Without Indy Kiwanians, we would not be able to have this amazing opportunity to truly place an understanding of the word international in Key Club International. Thank you sincerely for opening the doors to this limitless opportunity being a key clubber." I think she sums it up pretty well there.
Yeah, that's a great note. All right, Trina, you want to introduce our speaker today?
I would love to. It's my pleasure to introduce Dr. Jill Inderstrodt. She's an investigator with the Center for Biomedical Informatics at the Regan Street Institute. We've long been friends. We've shared a lot of miles of running. And through that, she's helped me to understand that despite some of the dismal maternal and infant health rankings that Indiana has, we have one of the most connected health information exchanges in the US. I didn't know that. I assume a lot of others don't. And the work that Jill's doing is incredibly important in advancing health outcomes. So I did ask her to come and share some of that with us so we can be better advocates in the community. But to share a little bit about Jill, she received her PhD in health communications and MPH from Purdue University before joining the center. Before joining the center, she completed a medical informatics fellowship with the VA's Center for Health Information and Communication. She's a research fellow with the NIH's Artificial Intelligence and Machine Learning Consortium to advance health equity and research diversity. It is a competitive fellowship aimed at increasing diversity in AI and machine learning research. She's also a Public Voices Fellow with the Op-Ed Project in partnership with Academy Health. Her writings as a Public Voices Fellow can be seen in the Boston Globe, Indianapolis Star, Slate, Education Week, and so many others. Jill also has had 2 tours with the Peace Corps. Feel free to ask her about those experiences. And she is a mom to a young daughter that is one of the most riveting humans that I know. Without further ado, Jill, thank you for being with us today.
Well, you just took like 5 minutes off my talk, so now I don't have to introduce myself. Thank you for that. Yeah, thank you so much. Am I okay to go ahead and share my screen?
Absolutely.
Okay. Oh, it says it's not turned on. Let me see.
Kelly, can you help with that?
Looks like we're good.
There it is.
Okay. Yeah, so thank you so much for having me today to talk about my work and the work of my teams at Regan Strafe. As Trina mentioned, I'm with the Center for Biomedical Informatics at Regan Strafe Institute, and I'm also assistant professor in health policy management at the IU Fairbanks School of Public Health. And so I kind of wear 2 hats, but they're very, very similar hats. It just means 2 bosses, 2 more sets of meetings, 2 trainings to do every year, but pretty much very intersectional work. And so whenever I'm listening to a speaker speak, I always want to know a little bit about them, maybe a little bit beyond their sort of professional bio. And so this is a little bit of both of what Trina shared and then some additional information as well. So I grew up in Indianapolis. I got my undergraduate degree at Beloit College, which is a little hippie liberal arts school in Wisconsin. My major was women's studies and just women's studies. I didn't have something to fall back on. I immediately, upon graduation, went into the Peace Corps in South Africa, where I did work around rape and domestic violence in rural communities. And so we did educational campaigns about rape and domestic violence. And so there I am. I was in a small town on the border of Zimbabwe. And Trina would not probably let me get through this presentation without mentioning that I was also with the circus. I worked with a new circus, like a Cirque du Soleil type group. I did not start the group. I just helped out. But there weren't clowns or animals, just trapeze and some very cool stuff there. Upon coming back, I got my a first master's degree at University of Texas at Austin. I say that my school spirit is greatly disproportional to the amount of time I was actually in Texas, but I do love Texas as a result. I then went back into the Peace Corps because somebody had to play sports on the beach with kids. And if they were taking volunteers, I was here for it. So I did a second tour with the Peace Corps in Jamaica. When I came back, I started teaching at Ivy Tech Community College in Indianapolis. And I was there for about 11 years while I completed my PhD and then later my master's of public health. And about 6 months before I was to defend my dissertation, I found out that I was pregnant. And so I worked on my dissertation, finishing up my PhD so that it would be done by the time I delivered my baby. And so at about 37 weeks pregnant, I walked across the stage as big as a house. I say that was the only time I was ever uncomfortable in my pregnancy was when I had to sit in the teeny tiny little chairs in the auditorium at graduation. Shook Mitch Daniels' hands. I had a very uneventful pregnancy. So my baby was always the size of the vegetable it was supposed to be, according to the vegetable baby comparison apps. I managed to paddleboard with my dog and my baby in utero throughout my pregnancy until my obstetrician begged me to please leave the dog at home. And so I complied. And even 2 days before my water broke, completed a triathlon with Trina as a team triathlon where I did the mile swim, she did the 10K run, and somebody did the bike, and I don't know him and I don't know his name. But we had a blast. And then the next day, the next night, my water broke. And I think a lot of new moms had big plans for my pregnancy, big plans for my delivery. I wasn't going to use any drugs. The water birthing suite at Community North Hospital was, of course, going to be available for me. No one else would have it. But unfortunately, what happened is that my water broke, and because I had Group B strep, I had which is a common strain of strep that pregnant women have. I was told to come into the hospital immediately. And what happened over the next 36 hours was a series of decisions and medical interventions that I did not, even as a maternal child health researcher, feel prepared to make. Even with a doula next to me, I almost say graduated, when I graduated with my baby, when I finally made it to the end and the baby was out, I was really disappointed in how things had gone. But I did walk away from that hospital. You know, they will give a baby to anybody who knows how to install a car seat. They don't require anything else of you. I drove away with her in the car seat, fully formed human, and was just a little frustrated with how my experience had gone. And then about 11 weeks after giving birth to my daughter, Charlie, I found myself as a single parent. This was not completely unexpected, but it wasn't necessarily an easy thing. And so this is a picture that I took on our first night as a fearless dyad of me and my kid, kind of looking into the future and not knowing what the future would hold. And so the reason
Jill,
that
if you're sharing your screen, we can't see it.
Yes, I can
my
see
screen
it.
at all?
No,
Oh,
I see
maybe
it.
it's
I
me.
can see it.
Yeah.
Sorry.
I think we're good.
You all right, Trina? Okay. And so when I talk about that, and I kind of talk about my why, moving forward in my academic work, my why has been that I really passionately believe that all pregnant people deserve the pregnancy, the birth, and the infancy that they want for themselves and their babies, whatever that might look like to them. And so my work is aimed at making sure that we can take away any unnecessary pain that any mom might experience from from the point of preconception until their baby is fully formed and bopping around and doing their thing. I don't really deal with the children after they are, 2 or 3 in terms of my research. Then I hand it off to somebody else to make sure that those children are happy and that those parents are happy. And so today I'm going to talk a little bit about stillbirth, which is a focus of a lot of my research. I'm going to do a bit of a segue into Indiana's information infrastructure, what we've got in terms of our ability to analyze extensive electronic health record data, and then talk a little bit about our surveillance work at Regenstrief and what we're doing to try to produce the research that will improve maternal and infant health outcomes. And so stillbirth in the United States is a baby that dies in utero after 20 weeks of pregnancy. Now, this varies from country to country and from health organization to health organization. So, for example, the World Health Organization puts that, I believe, at 26 weeks because of viability. In the United States, if you make it to 20 weeks, you think, even if something happened now, I think that this baby could be put on many different medical interventions that might allow it to survive. And so in doing stillbirth research, we're not necessarily ignoring the pain and the complications that miscarriage bring with them. But with stillbirth, we do feel like it is a unique situation in that moms are expecting that viability at that point. And so stillbirth results from a lot of different causes, and we don't know all of these causes, and we don't know how all of these causes factor in stillbirth, but it can be from pregnancy and labor complications, issues with the placenta where the placenta cannot get the necessary nutrients to the fetus that it needs to, congenital abnormalities, which a lot of times they're not preventable, but information about them can be used for future pregnancies for mom or to figure out how to manage the pregnancy that they're currently carrying. Infections, I mentioned that I had Group B strep, which is a common cause of stillbirth, especially for moms whose water breaks and then they're more susceptible to infection. Issues with umbilical cords, hypertensive disorders like preeclampsia, HELP syndrome, which is basically high blood pressure in pregnancy that can be lethal to both mom and baby, and then just various other medical problems. I sit on the Fetal, Maternal, and Infant Review Committee for Marion County. I visit various other FEMA boards throughout the state, and there's various conditions that cause babies to not be able to survive past 20 weeks. And just as an aside, and I'd love to come back and do a whole other talk about health disparities and health equity in maternal and infant health outcomes, but stillbirth is 2 times as likely in US Black women than in US white women. And this is for a variety of reasons, most of them not related to the fault of the mother themselves. Most infant health outcomes are not related to the fault of mother themselves. But the conditions are a little bit different. So Black women are more likely to experience stillbirth due to labor or pregnancy complications or infections. And they're also more likely to have stillbirth during that labor and delivery process. So a lot of times we think about stillbirth as, you go into the hospital thinking that you're going to have a live birth and the baby's died. But most of those stillbirths actually happen 20, 22, 24, 26, 28 weeks. And Black women are also at very, very high risk of preterm birth too. Again, for myriad reasons that I won't go into during the scope of this, but would love to answer questions about later. And so Indiana, we have some pretty dismal maternal and infant health statistics. We are ranked very, very high for infant mortality, very, very high for maternal mortality. For stillbirth, 1 out of 165 live births results in a stillbirth. ChatGPT actually made this picture for me, and we had to go back and forth considerably. So I don't actually know if there's 165 babies there. But I will count after this. ChatGPT could not get the numbers right. That's about 500 babies a year in Indiana. Many of those preventable, many of those not preventable. But again, we don't know because we don't have all of the requisite information. So stillbirth is really, really hard to study from an information standpoint. And so I want to talk about the different levels of challenge that we see here. So one of the reasons it's hard to study is because of government, the way that government functions related to infant and maternal health. So Medicaid does not pay for stillbirth autopsies. And one of the main ways that we get information about a stillbirth and the reasons why a baby died in utero is through an autopsy. So if you're on Medicaid and you're offered an autopsy, you're going to have to pay for it out of pocket. That results in many, many fewer autopsies than we think that we might have otherwise. At the community level, while we in Indiana have the Indiana Health Information Exchange, which Trina referenced during the intro, many states don't. And so many states find it very difficult to share information across hospital systems that make it difficult to figure out if there are trends in stillbirth or in other adverse outcomes. At the hospital level, the hospital has to be committed to getting those autopsies, to treating moms with care and respect in a way that allows them to provide us with more information. And they have to have the infrastructure that allows us to get that information, to contribute it to our exchange. At the interpersonal level, it's very, very difficult to talk to families who have experienced loss about getting an autopsy on their baby. Many families have very strong beliefs about the mutilation of their baby's body. And doctors and nurses don't feel equipped to have those difficult conversations. And so there's a gap there in our ability to obtain that information. And then finally, the individual level. I mentioned individual personal beliefs, individual socioeconomic status, and just the overall trauma of experiencing a stillbirth that could affect whether or not parents decide to get more information about their baby's death. Moms are also really afraid that they were to blame for the stillbirth, and overwhelmingly, it's not their fault. Most of those reasons, those predictors that I mentioned, are not things that a mom can control. And so when we talk about surveillance of conditions, a lot of times the word surveillance can be really scary, right? We think about, government oversight, government kind of like snooping around in our health information. We in the United States consider our health information to be very private. We are guaranteed that we will not have to share that. I don't know if anybody, and you can use the raise hand mechanism on Zoom or the chat. I don't know if anybody was contacted by a contact tracer during the COVID-19 pandemic. But I was one of those contact tracers calling people to let them know that they had a positive COVID test, ask them who they might have exposed to COVID during the time that they were sick, creating the timeline and trying to figure out what windows of time they might have been contagious, and then contacting their close contacts to let them know that they had been exposed. And I know that, depending on who I called, depending on what language they spoke, people were overwhelmingly very suspicious. They want to know why you know things about their health. And so I'm hoping that some of what I talk about today will kind of illuminate why we conduct these sorts of investigations. Public health surveillance is the collection and then management and then analysis and interpretation of data, and then disseminating that to the proper entities so that they can create programs and policies that will help to solve a health problem. And so for us, a lot of the surveillance work we do, we collect Hoosier Health data, we analyze that data, and then we report that to the CDC, who then combines it with other states to try to figure out if there are trends across the United States, to the Department of Health, to Marion County Department of Health. We're not trying to figure out who anybody is or who anybody's name is. We're trying to figure out where the trends are. And so this can be a bit mind-boggling. This chart sometimes stops me in my tracks as well. But I'm gonna take it piece by piece so that you can understand how our surveillance systems work. So the first input of data that we have into our surveillance systems is called the Indiana Network for Patient Care. And so when we talk about how we have a very interconnected health information exchange, most of the major hospital systems in Indiana have agreed through a governance process that they will submit their electronic health records to this network, to the Indiana Network for Patient Care, INPC. It includes things like medication orders, lab reports, vital statistics, sometimes autopsies, but then also different information based on the healthcare system. So for example, IU and Eskenazi Health, they collect very extensive social determinants of health data that they submit. Community also collects some other data that other systems might not. And so we get some very common data like diagnoses and labs, but then we also get some different site-specific data as well. And so that's updated nightly in the IMPC. We at Regenstrief don't own this data. We're what's called the honest data broker. So our analysts can pull that data. You have to pay them a lot of money to pull that data. We have to technically buy it. But they can only do that for entities that have a data use agreement in process, which is a very, very long process to make sure that we are making sure that we are protecting everybody's personal health information at all times. The INPC contains over 123 hospital connections, representing over 38 health systems, 19,000 practices, over 54,000 providers in Indiana, over 20 million patients, and over 16 billion clinical data elements. And so that includes, like I said, labs, vitals, encounters, diagnoses, all of those. And this is the extent of the Indiana Network for Patient Care. And so as you can see, for most of Indiana, 90 to 100% of their electronic health records are covered in a county. We have a few holdouts for different reasons, but the Indiana Health Information Exchange, which kind of technically owns the data process, is always working to bring new providers in. We also don't have some more independent providers. We don't have like nurse midwives who might be operating on their own, or lactation consultants. We don't have a lot of home birth information. So there is some information that is missing. But about 70% of Indiana's health records are contained in the exchange, and 90% of Hoosiers have at least one encounter in the exchange. So we take that electronic health record data, and then we take what we call public health data or administrative data, which is stuff that comes from the Indiana Department of Health. This is the Indiana Birth Defects and Problems Registry. Anytime a baby is born with a birth defect, that is submitted to the state so that we can track that over time. And by we, I mean the public health system, but the Department of Health. Newborn screening, when you have your baby, it goes in and gets its heel pricked, and they run a bunch of tests on your baby's blood to see if they have any genetic conditions or any other kinds of conditions. That all goes in. And then the division of vital records. For some researchers, that's birth certificate data and death certificate data. For me, that's fetal death certificate data, which is something that we use to see where might we be missing cases in the electronic health record. And then we can also see for which cases in the electronic health record we don't have a fetal death certificate and try to figure out what happened there. And so we take all of this data, we match, for example, the death certificate data to the individuals in the electronic health record, and then we produce various products. We submit to the CDC. We are on a couple projects I'll talk about at the end where we are submitting data to CDC. That's all de-identified data. It doesn't have any names or addresses or any other kinds of identifiers. It's just cases. We produce our own research and analysis. So we publish in academic journals. We present at conferences so that other people can learn about the cool stuff that we're doing. And then we also report to our partners at IDOH, at Marion County Public Health Department, and other health departments that then use our findings to change, improve, or incite programs and policies that will help to change health outcomes, in our case, maternal and infant health outcomes. We also do a fair amount of presenting to government, to legislature, through reports and testimony. And so there's some challenges in stillbirth surveillance, aside from the fact, that there are so many data sources. A lot of times we have trouble locating different pieces of information. For me, again, one of those pieces of information that I really need in order to do good research that results in change is finding the autopsies that belong to the families. Those are often conducted in a separate electronic system that I am now trying to hunt down and figure out how we can access. A baby that is given an autopsy is often not given the same medical record number as they are in the electronic health record system. And so it makes it very, very challenging to hunt down those reports. Sometimes often they will do reports on the placenta or the umbilical cord. Sometimes we find those in mom's record. Sometimes we find those in baby's record. It's a very fun part of my job, actually, is trying to hunt down all of this data, figure out where it lives, and figure out how we can integrate it into our systems. We might be missing data points, or there are a lot of times misdiagnoses. So we do chart reviews where we actually go through every single stillbirth case that we have that is by diagnosis code. But a lot of times those are misdiagnosed. A lot of times they're miscarriages that are misdiagnosed as stillbirths, or they're stillbirths that are misdiagnosed as miscarriages. Fetal death records, fetal death certificates are really unreliable. And I was actually on a call with the CDC and some of our other partners this week. And I initiated a conversation because I said, we just had this really cool thing happen where our fetal death certificates were being originated at the funeral home. But fetal death records include a lot of hospital-based information. And so these funeral directors were the ones who were having to run around to the hospital, call doctors, try to figure out what happened. It includes things like how many prenatal care visits did they have? So we've got funeral home directors who are trying to figure this information out. And a lot of times the information just doesn't get filled out, or it's not reliable. I have a hard enough time determining how many prenatal care visits a mom had using electronic health record data, not to mention just running around with, essentially what is a piece of paper trying to figure this out without having access to their health record. However, on July 1st, 2025, legislation was passed that as of July 1st, 2025, the fetal death certificate now originates in the hospital. So we're hoping that this is going to fill in a lot of the blanks around some of those missing points that we really need to know. It's important to me to know how many prenatal care visits mom had, either to determine if that is somehow predictive of adverse outcomes, or if it can tell us something about the mom and the mom's access. Social determinants of health data is a really interesting case. So that's data like food insecurity, housing insecurity or homelessness, intimate partner violence or domestic violence, even things like transportation and ease of transportation to get to appointments. A lot of hospital systems right now are collecting this. I know I have a doctor's appointment next week with Community, and I already got sent my survey. Please fill this out. People don't understand why they have to fill this out. I was listening to a podcast the other day with two famous actors, and they were going on and on about how awful it was that they were being asked their race when they went to the eye doctor. And so I actually wrote an email to the podcaster and I said, here is why. It's because we want to know why and what kinds of people are losing their vision who have also been on GLP-1 medications, on medications like Ozempic, which is a thing that we're seeing. It's a trend that we're seeing. We're not going to know if, for example, Black people are prescribed a medication more or less than white people if you don't tell us who you are. And so that data can be inconsistent because people don't want to fill it out. They think that it's extraneous or they think that it's invasive into their privacy, not realizing that the end of that is actually trying to improve health for everybody. So Community Connect collects that. Eskenazi and IU collect that, but they ask different questions. They ask them in different ways, and they have different options for answers. And so when we try to put all of that data together, it doesn't match up. It's like taking, a couple different columns in an Excel spreadsheet and trying to make the answers match that don't match. And so that becomes a huge challenge when we're trying to figure out who is getting sick and why. And then finally, and I hope that you'll indulge just a little, this is truly wonky, and I understand if you want to turn your ears off. But we have issues with matching moms and babies in the electronic health record. So if I'm a physician, and I go to Mary Smith's electronic health record, I don't just have a drop down that tells me who all her kids are. I don't have a drop down that tells me who her spouse is. And this can be really good, especially in cases of, intimate partner violence or domestic violence. We might not want people linked in the electronic health record. But if I'm trying to investigate why a baby died, or if I'm trying to investigate why a baby has a certain condition, a thing I really need to know is who the mom is and what the mom's health status is. And I can't just do that by going to baby's chart and then automatically finding mom's chart. And so at Regan Streif, and by we, I do not mean me, I mean my colleagues, have come up with matching algorithms that allow us to link moms and babies in the health record. And this has been instrumental for us in producing better and more predictive data when it comes to, this is a fake medical record right here, but you can see that the mom is listed with the baby underneath. And even this is just really big for us on the back end of the data because we need to be able to link those moms and babies. And you can link those in lots of different ways. If you think about the fact how many moms don't have the same last name as their baby, how many people might move and not update their address, and so baby has a different address than mom. It's not so simple as just going in and saying, oh, these two must be related because they have the same address or they have the same phone number, although we usually try that first. And oftentimes email address is a lot of times email address is actually a really good one because email addresses are so unique and have so many weird kinds of, letters and nicknames and things that if they've put that for their baby's email address, that can be an easier way to determine whether or not that's a pair. But we might have to go a little bit deeper into the demographic data in order to link those pairs. And so finally, I wanted to just name a couple of projects where we're doing this kind of surveillance work. The first two are from CDC. I did mention this that we're doing large-scale surveillance of stillbirth in Indiana and that we're collaborating with, I think it's about 8 to 10 other sites throughout the country to try to look at both the predictors and the outcomes of stillbirth, but also to look at the way that all of our data is structured differently. Each healthcare system has its own way of structuring its data. Like I said, we're really lucky in Indiana, and people are always shocked because our health outcomes are awful in Indiana. However, our our health information exchange is one of the most envied in the country. And so we're trying to figure out how we can modernize our data so that we can better do surveillance of these conditions. We're also surveilling neonatal abstinence syndrome, which is when babies are born with opioids or other substances in their body that their body craves. We don't say that the baby's addicted, but the baby's body is addicted to the substance. And then also congenital syphilis. Syphilis is a real problem across the country and in Indiana. And we're seeing cases of syphilis where the baby is born to a mom who has syphilis and doesn't know it, just absolutely skyrocket in Indiana. And that is a huge risk for stillbirth and other adverse health outcomes for the baby long term. I also have a project where I'm doing surveillance of congenital heart defects along with a pediatric cardiologist from Riley, Dr. Larry Markham. And we are looking at what kinds of people are getting congenital heart defects, who is getting care, who's getting surgery, what demographics of people are getting surgery, who is being lost to follow-up when they turn 18 and have to transition into adult cardiac care. And we also have a policy piece to that. So we're trying to figure out how do Indiana's policies affect the lives of people who have congenital heart defects. And then some other work that we're doing that's not necessarily surveillance directly, but is using the INPC and the electronic health record database that we have access to, which is, the name is very long. It's the Indiana University Better AI for a Strong Rural Maternal and Child Health Environment, or BEAR Lab. And I, along with my colleagues, have developed an algorithm that will predict preeclampsia using very, very basic electronic health record data. So it could be used, yes, here in Indiana, where we've got really rich data, but it could also be used in a state that doesn't have a very developed system. And so we've been giving funding to start this lab so that we can apply our algorithm to AI tools that can help in obstetric deserts in Indiana. So about 40% of Hoosiers live in an area where they don't have easy access to an obstetrician or even to a labor and delivery unit. So they might live 1 or more hours away from a place where they can deliver their baby that's not an emergency room. And so we want to get ahead of some of the conditions that cause preterm birth and labor complications by putting AI tools in moms' hands so that they can communicate with their physicians who live in larger cities like Indianapolis, Fort Wayne, Bloomington, West Lafayette. And so that's one of the major initiatives that we have currently. And so just to sum up, that tiny baby that was born after hanging out for many, many hours deciding not to be born, and we always say, and Trina will appreciate this, that she was the first of us to ever have done anything early. Because myself and her father are never early for anything, but she showed up. She did pick up the water sports that she had participated in utero. That's her first kayaking at about 18 months. She learned to paddleboard with both her mom and her dog, as she had done before she was born. And she now paddles her own paddleboard around like a pro. She is a very high energy child who loves ballet, fruits and vegetables, and lives her life with quite a bit of flair. And whenever I get frustrated, or to be very honest, annoyed by her very high spiritedness, I do think about the work that we're doing at Regan Strafe and IU to make sure that moms can continue to be annoyed by their children from birth and well into adulthood. And so I thank you for listening to this presentation today. Here's my contact info, if you have any further questions, and I believe that we've got some time that I would be happy to answer any other questions that you might have about the presentation.
No,
I don't know if
Go ahead.
Oh, go ahead, Roger. Go ahead.
I was going to say,
Sorry,
great presentation. I know there's a lot going on with pregnancies and such, but kids do grow up and you eventually like them.
Yeah.
So you're in for a good turn right down the road.
Yeah.
They keep telling me it's the best age, and I am not convinced.
Oh, they're all the best
all the
age. They're
ages
all
are
the
the best
best
age.
age. Yeah. Yeah.
So thanks for what you're doing.
Yep.
Thank
Very
you. Thanks so
important.
much for listening.
Yeah, I appreciate it. It's so do any of the changes, and I say that because I'm making the presentation from the design space over at IU Health. Do any of the changes that IU Health's making in terms of the relocation of the business or the med school and the hospitals impact at all what you guys are going to be doing?
I don't know. You know what can impact is electronic health record system transition. So I believe IU Health is going to be transitioning from Cerner to Epic. And I was with the VA before this, and we were transitioning from some other thing that only the VA used to Cerner, which the VA has the largest and longest electronic health record system in history. Billions and billions and billions of data points. And so what that does for us who are working on the back end is that it does make it challenging for us to design products that can help physicians and patients, because we have to design them. We have to decide, are we going to design them for the two systems? Are we going to design them for the system that they're moving to next? But there's a lot of good work being done at IU, and we collaborate with IU Health. I mean, we're in meetings and networking sessions with them constantly, because one of the things is when you're trying to implement new processes or products into healthcare, you have to have a clinical champion, and that can be very challenging because doctors are busy. Doctors are very busy. They don't always have time to try a new thing. And so one of the things that IU Health has been really good about, and Regenstrief have been really good about, is trying to bring physicians and researchers together so that we can more effectively implement changes, test those changes, and then continue them if possible.
Well, it's been fascinating to see how much Epic has influence in the design of the spaces that we're working on. So it's a monster, but it hopefully will result in good records for you guys to deal with. So.
Right. And more, I think more opportunity for patients too, to have, more control over their health
Yeah.
record, more access to
I
them.
know they're pushing hard to try to go paperless as much as possible for check-ins but different populations have different success levels of that. So.
Right. Well, and to speak to that too, there is a skepticism. There can be a skepticism, and totally understandable, especially in VA. We had this because with VA, a lot of times you have to opt in to different kinds of sharing, and so the veterans just no, I don't want you sharing this. I don't, and so I do believe, as an informatician, there is this sort of happy medium where we have to find an area where patients are assured and comfortable, and researchers aren't asking too much without really consulting communities.
Do you interact with other agencies within IU Health, other groups? My daughter works for Simon Cancer Center. She's on fellowship looking at HPV viruses for children.
Oh, that's great. Yeah. Well, it really depends on the investigator. It depends on the researchers. So I have a colleague, we actually just submitted a grant together, again, focused on rural areas. And she does have cancer center affiliation as well. I am most closely linked with the maternal fetal health medicine physicians and the pediatric cardiology clinic at Riley. So most of my collaborations come out of Riley. And then a little bit with OBGYN at IU Health. But I have found some champions in the maternal fetal health medicine or maternal fetal medicine unit who are very excited about the work that we're doing and are here for it to facilitate.
So you're connected to most hospitals in the state?
Yeah, most hospitals. The system in Terre Haute is not part of the exchange yet. There's just a couple of outliers, and then also just anybody who's the smaller systems who maybe aren't part of a larger system or just smaller practices. And part of what part of what we find out every time we do research is, where there might be gaps and where it might be helpful to bring other people on board. But everybody kind of has their own reason. And also when you're talking about border states too, a lot of times when we're doing studies, we're talking about things that happened in Indiana, but it doesn't necessarily describe something that happened to a Hoosier, because it could be somebody who lives in Plainfield, Illinois, but comes to Indiana, or somebody, especially when we're talking about reproductive health right now, there's a lot that's happening in Indiana legislatively that isn't good for moms. And so moms are going to other states for care and then coming back for their obstetric care, the reproductive health care, and then coming back into Indiana to get their primary care. And so we don't know a lot about what happens in between that time. And so that can be very frustrating.
I appreciate that.
How far back in the records do you guys go in terms of because I know healthcare processes have changed a lot. And I know we've had, stillborn issues in our family, but that's historically extended, into the 60s. And so do you dig that far back, or is it primarily
I
the
haven't
last?
had to, just because anytime we conduct a study, it's usually based on certain years that somebody wants. So for me, CDC wants 2020, 21, 22, 23, just anything from 2020 on.
Yeah.
It becomes more and more expensive the more and more records you pull too. So, and the data becomes less and less reliable and becomes less and less complete. So we can theoretically pull some data from the 90s, but we're not necessarily going to have the same kinds of information that we have, that even if we, that we pulled from 2010, or even, the difference between what we have from 2010 and 2020 could be, especially we're talking about things like social determinants, things that they just started collecting. We're kind of adding new things to collect regularly. And so it just depends on what you want to study and how little viable information you're okay with.
Okay. Any other questions?
Well, I really appreciate the
All right.
opportunity to talk about my work, and please reach out if you have other questions, or you have other folks who might want to talk about the same thing.
Well, thank you very much for doing it. It's been an interesting talk. The Kiwanis Foundation of Indianapolis will be making a donation in your honor to Hear Indiana. They deliver hope and resources to Hoosier children with hearing loss. So,
thank you so much.
Sure thing. My daughter's studying to get her doctor of audiology, so it's near and dear to our hearts here. So,
all right, and Trina and I are one of our best swim friends. Her daughter is a newly minted audiologist.
Excellent.
Yep.
Excellent.
Yep. Very cool. Well, I'll be very excited to share that with her as well.
Okay. Well, terrific. And we always close with some information from the One America signboard, the wisdom of the One America signboard. This one that seemed a little bit telling with the floods that we've gotten this week. It was need an ark. I know a guy. So
know a guy, right?
I know a guy.
I'd like to meet that writer.
I think it's multiple. I think they have an editor primarily. So, but thanks very much, everybody. And we'll see you next week at the Columbia Club.
Thank you, Jill.